Today we welcome Professor Baker. He is consultant on pediatric hepatologist at King's College Hospital. Thank you very much for joining these interviews. Professor, how have been your experience during this pandemic?
Thank you very much. I was asked to answer some questions about the nature and experience of COVID and paediatric liver transplant services at King's College Hospital in London. I'm very pleased to try to do this, and I hope that the information I give will be helpful to everybody in the European Reference Network. The first question is to explain the government lockdown policy. The government lockdown policy in the UK was later than elsewhere, and I think it was in keeping with the philosophy of the government of trying to persuade people to do things voluntarily rather than compulsorily. So from the 16th of March, the government recommended no non-essential travel, and from the 20th of March, they recommended that businesses close, but nothing became obligatory until the 23rd of March, when there was a nationwide lockdown. And the lockdown meant that people had to have a reason to leave home. Only key workers, essential workers, could go to work. People could have 1 hour a day outside their house for exercise. They could undertake essential shopping, and the essential shops were kept open, like food shops and some other commodity shops, but most shops were closed. It was possible to leave the house to get medicines, and to obtain appropriate healthcare if it was urgent, and to help others in an urgent situation. Simultaneously, on the 23rd of March, the government introduced a concept called shielding, which is the idea that those people who are at increased risk, particularly those over 70 and those who had chronic illnesses, especially those who were immunosuppressed, had respiratory diseases, should be put in a situation where they shouldn't leave their house at all for 12 weeks, and they would have food and other supplies brought to them, which has been organised by a variety of different sources, and I won't go into that. But those patients who were shielding, of course, the rest of their family had to be shielded with them, and that was important for young children, either those on the transplant list with chronic liver disease, or those who had undergone transplant and were immunosuppressed, because their whole family could be locked down or shielded together, and their parents couldn't go to work. And that situation was meant to be applied for 12 weeks, but it's just coming to an end now. And finally, I think with respect to the shielding business and families, that has caused considerable problem for them, both economically, because they're confined to the house, and socially, that families with 3 or 4 children and parents, or maybe one parent, confined to a sometimes quite a small apartment, have been under considerable pressure. And the weather's been hot as well, which in British houses is not always helpful. How has hospital activity changed to adjust to the pandemic? The pandemic hit the UK probably 3 weeks or so later than Italy, and maybe 2 weeks later than Spain. But the government's response was, I think, more liberal with a small L than perhaps it might have been in retrospect. And people didn't respond as quickly as they could have done or should have done, and neither did the government. Nevertheless, it became clear that this pandemic was going to hit us in March, and over a relatively short period of time, certainly in our hospital, the hospital reorganised its management structure and function, and put it more almost like on a military footing, with a gold command and a silver command, and regular meetings, and all your departments reorganised to meet regularly, usually with Zoom meetings for the most part, or team meetings. And as a result of that, it was possible to move the hospital around very quickly. The hospital had about just under 60 critical care beds in all specialties for adults, and 16 including high dependency for paediatrics. And over less than a week, operating theatres, recovery areas, certain of the wards were turned into critical care areas, so that the target was 200 critical care beds. In fact, over that week, just over a week, nearly 160 adult critical care beds were prepared for COVID, which was a remarkable achievement. In fact, the anticipation was that there would be a tsunami, and that was the word they used, of adults ventilated with critical care. And of course, there would be a number of people over 70 years of age or with morbidities which signified a poor prognosis who wouldn't go to critical care. So other wards were converted as well for respiratory nursing and palliative care for those who inevitably would die as a consequence, particularly amongst the older people, and, as I say, with more other morbidities. And so the hospital became a COVID hospital over a relatively short period of time. And fortunately, neither the respiratory unit for the palliative care nor the critical care were overwhelmed. At one point, we had over 150 patients in about 160 beds for critical care, but the situation coped. We had problems with personal protection equipment, gowns and this kind of thing, and so but that was a national problem of supply and organisation. Once again, there always was equipment in our hospital, but some of it was, I think, they didn't know in any weekend whether they were going to run out or not. I think they didn't run out, but they came pretty close to it. In some other places, they did run out. So during that time, of course, paediatrics had to move away, and we had to supply medical and nursing staff to critical care services. Anyone with any experience of a particular job or who could be trained quickly for that kind of job was moved elsewhere. But we still had the core of nurses and doctors to go on doing work. And we made the case successfully in paediatric liver and paediatric liver transplantation that these patients could not be treated anywhere else. So we managed to retain 4 paediatric critical care beds for all paediatrics, but the liver service was the one that used it most. And we were still able to do that work. And the liver ward took on other high-risk patients like hematology. So we had a small number of patients there, and the work reduced because no elective work took place. So there was no elective surgery and no elective endoscopies or liver biopsies or anything of that sort. And at its quietest, the ward got down to about 6 or 7 patients. So in essence, we kept on working. We lost a certain amount of resources. There were things we could no longer do, but we continued to do transplants. We transplanted we transplanted 9 patients over 2 months, all successfully. With respect to COVID infections, we've only seen 2 in liver patients, and one is important from the transplant point of view because this was, I won't give specific details, but this was a patient with chronic liver disease who became COVID positive and was mildly symptomatic, but over 3 weeks cleared the COVID and went to a transplant with very poor liver function. So the transplant was delayed, but fortunately the patient's outcome was good and once the COVID was cleared. How about donation and the transplant program? Well, as I mentioned, the numbers of patients assessed for transplantation were reduced, but we were still assessing one approximately every week. So the list was continuing to be turned over, but not as fast as we usually would. And the numbers of transplants, as I say, went up a little bit. And then other operations, complications and things like that, if they were indicated, we still continued with those. With respect to donation, donors still became available and in the way that one would expect. So I don't think we were too much affected by that. So the next consideration is outpatient care for paediatric transplant children. We stopped doing outpatients and day case visits very early on during the lockdown from early March, mid-March. And instead, we adopted initially telephone clinics, and more recently something called Attend Anywhere, which is a video clinic, rather like a Zoom or Teams meeting. It's got an additional facility of a waiting room, so people, parents or families check into the waiting room, and we see them on a screen, and then click on them, and they enter the consultation. And it's possible to include other people as well, so it's possible to have consults from other paediatricians from around the country if we organise that. And that's working very well. So in my opinion, what are the main issues that may arise in the short term due to both the transplanted and waiting list children? I think the main issues for children, perhaps it would be better to ask the patients than me, but the ones that I see are about returning to school and returning to normal life in terms of social interactions, and the risk of COVID being introduced to the home. So it's how close to normal life are people going to return, and what are the risks that they're willing and able to take in the meanwhile, and how do we explain to families what those risks are and allow them to decide whether they're appropriate to take or not. The issue for families, I think, is the fact that they are all very worried about what happens if anyone in the family, and particularly the patient, gets COVID, and will that be life-threatening, and will it cause, for example, their liver to fail? Will it cause them to end up on a critical care unit, and could they even die of it? I think the risks, for the most part, so far have been low for children. Not to say none, but low. But nevertheless, they don't want their child to be the one who loses their chance of a transplant or loses their life as a result of COVID. So they have been, many of them, very, very worried. And they would like, at the same time, they don't want to, for example, lose work unnecessarily or lose schooling unnecessarily. And they are, I think they would like to have their normal social interactions. They'd like to be back with their friends and not within their house. So they're looking to us to tell them, indicate to them what's possible and what's reasonable. And I think that we have some ideas, but it's almost got to be spelled out, each family one at a time, and or discussed with each family one at a time. And we don't have time or resources necessarily to do that one by one for all the patients. And it wouldn't be done once and for all. It would need probably regular discussions about how things have changed in the world generally and in their family also. Are there any special measures for these patients that should be put in place now that the healthcare activity has begun? My feeling is, just to have an idea off the top of my head, would be that I think families might like to talk about their experiences and to have recommendations and experiences and people telling stories about what their doctors did for them or with them or explained to them, and what their perception of their risks and how they would limit or not limit their lives, and what the outcomes were. Thank you very much.